folks a few minutes to jump on, so feel free to make yourselves comfortable wherever you are, get some kind of fun beverage, or I don't know, put your feet up, and we'll get started here. Wow. Hi, Louisiana. I see Louisiana people. Hi.
Hi, how's it going?
Good.
Hello.
Good. This is great. And also I have to say, this is exciting to see a lot of names that I don't know, which hasn't always been the case for these events and gatherings, which is really cool. We can go ahead. They're still coming in. I'm going to give it just a minute. Hold on. All right. Hi, Oklahoma. Good to see you. Right, so I feel like we've given that obligatory kind of 2 minutes to log in, and I'm just going to ramble for a little bit. That's pretty much what I've been asked to do, so we can go ahead and get started. So welcome everyone. This is really exciting to see so many folks able to join this this conference, this little mini gathering, convening, virtual event that our lovely team over here at NASTAD has pulled together. Yes, Linda, good to see you. That has managed to pull together over the last many months. There's been a lot of excitement and thoughtfulness and planning, and you know, it's always a little bit of nerves when you start a thing right before you get going with a thing, but I am beyond sure that all the planning and all the work that has gone into bringing this event together from folks for you all will pay off in droves. This is some of the history and background of some of these. Well, first off, I'll say, so I'm Laura Pegram. I'm the Director of Drug User Health over here at NASTAD. I am based in New Orleans, Louisiana, though we work all over the country. For those of you who are less familiar with NASTAD, I'll just give a little 1,000-foot view. We are a national membership-based organization that primarily works with all the U.S. state health departments, their HIV and viral hepatitis, and increasingly over the years, drug user health programs. Our work as a drug user health team has expanded exponentially over the last many years, which is, as you all know, a clear indication of the need. There's an enormous amount of need, huge increase in programs and services that are starting up all over the country. I mean, really looking at when I started at NASTAD a few 4 or 5 years ago, I mean, we were at just about right at 200 programs across the country, and now we're close to 450. I would say even a bit more than that. So the need is so clearly there, and you know, we are excited to over the last many years have been awarded the trust and some resources from our CDC partners to provide technical assistance to programs directly on the ground, which you know, doesn't sound like a very like enormous feat, but actually it's kind of, you know, the first time that programs can really work with us directly, not necessarily through a health department or a single state agency, really just like in the spirit of harm reduction, providing a lot of agency to programs, and really broadened our team and the work that we're able to do. So yeah, working with both health departments to help support programs and help figure out those things, and then also with programs on the ground. So the history of these meetings, let's see, we used to do them in person, just like everything, but about 5 years ago or so, NASTAD and our other SIVA capacity building assistance, CDC funded partners, all came together, recognizing that there was a real need to have these conversations that are focused regionally about how to build support for syringe access. Plain and simple, right? Really acknowledging that a lot of old school harm reduction kind of is centered on the coasts and comes from New York, and that messaging in New York City is very different than New York State, but messaging in New York is very different than messaging and building support for programs, strategies to build support for programs here in Louisiana or in Colorado or in Idaho, and that regional approaches, because of cultural commonalities, are really, really an important opportunity and place where we can be strategic and offer a space for people to meet people, because sometimes, especially in the South, we can feel really isolated in the work, and that can happen anywhere, obviously, but like sometimes I feel like Morgan's on this next panel. I mean, we'll see, you know, I feel like all of our panelists today have already told me some of the ways that, you know, they're the only game in town, right? And that can feel hard. And we know that the work we do is just incredibly, incredibly important and life-saving and hard. So acknowledging that this is hopefully going to be a space for you all to really get some skills. There are some sessions that cover more content and didactic areas, some sessions that are more focused on really thinking through strategic communications or unique strengths and perspectives about working in the South and building support for programs in the South, but then also really offer that space for networking, really offer that space to really get connected to people in our region who are doing this incredibly important and hard work. So we at NASTAD always really believe firmly in regional approaches to offering support to programs. I believe many of you, if you're not on the calls, we have rotating weekly calls for that's similar to these institutes, kind of rotate around 8 different geographic regions in the country. And those are often spaces for real social support. So, and just, you know, sort of troubleshooting and updating what's going on in community about trends and such. So always glad to be creative and thoughtful with you all, because you all are doing the work. And we all are basically paid to help you make your job easier and do the work easier, right? So really always excited to be hearing from you all, in space with you all. And if there are ways that we can help you, pays us to do it. It's very exciting. And so I don't want to take up too much time here, but you know, we are excited to have you all here. This is our second virtual convening in the South, so you'll see some familiar faces. And like I said at the beginning, I'm really excited to see a lot of faces, a lot of names I'm not as familiar with. Because harm reduction is about welcoming and bringing people into this fold. So excited to help create that space and hold that space over the next two days for you all. So I'm going to toss it over to Alika, and Alika is going to tell us a little bit about housekeeping and Zoom links and all the things that that I clearly haven't caught up on. So welcome. I'm really excited you all are here, and yeah, excited to be here.
Thank you so much, Laura. And yes, my name is Alika Upadhyay. I'm an associate on the Drug User Health team. And I'm happy that you all are here today for our first day of the Southern SSP Institute. And so just to run through a couple of logistics, all of these sessions are going to be recorded and later uploaded onto the NASTAD website. And any slides that are presented will also be uploaded there as well. All links can be found in the Eventbrite platform and also in the agenda that was sent out earlier last week. If you're unable to find them, just feel free to reach out to me or the Drug User Health TA email, and we can forward them out to you. And we'll also make sure to put them in the chat when we're going into our different breakout rooms. And as a reminder, please mute yourself if you're not speaking at that time. And we will also I've enabled closed captioning for this session, and we'll do it throughout all the sessions. If it's not showing up on your screen, you can click the CC button on the bottom right screen, and it should come up at the bottom. And if there are any more questions, feel free to message me or reach out to the Drug User Health TA inbox, and we should be able to help you out. And thank you all again. I will pass it over to Mark and Abiel.
Thank you so much, Alika. I wanted to say welcome, everybody. So now we're going to go ahead and kick off with the opening plenary titled Harm Reduction in the South, Creativity, Innovation, and Resiliency in the Region. For those who don't know me, my name is Mark Lockwood, and I'm the Senior Associate on the Drug User Health team. And today I'll be co-moderating the panel with my colleague, Abiel Gebrehiwot. Abiel, you want to introduce yourself?
Yeah. Hi, everybody. My name is Abiel Gebrehiwot. I use he, him pronouns. I am a manager on the Drug User Health team on the COVID SSP project. I have some experience doing harm reduction in the North, so I'm excited to talk about what harm reduction in the South looks like and to get to meet all of you wonderful folks.
And so a little bit about this session. So I'm going to read a bit of the description of the session. So regional cultural values of resiliency, community innovation, and individual rights have facilitated uptake of harm reduction-based programs in various settings within the American South. Southern harm reduction programs are strongly influenced by the environments, traditions, power structures, and resources in their community. Learning to effectively respond to and leverage these influences can encourage development of unique programs that support participants in creative and innovative ways. This opening plenary will highlight current strategies and perspectives from programs across the South, providing insight to how programs develop innovative service delivery amid the many barriers faced against them. So we're really excited to be here today with you all, to share space with you all, to learn and engage with one another, and just to be in conversation with one another. I'm here with 4 brilliant and lovely presenters who will be in conversation with us today. Dr. Robin Pollini from West Virginia University, Morgan Farrington from GoodWorks North Alabama Harm Reduction, Jessica Blanchard from 229 Safer Living Access, and lastly, Thalia Nakouzi from the Louisiana Department of Health. We are so excited to have you all join today. Could you all just introduce yourselves, talk about, one, how you came into this work, a little bit about your background and some of the scope of work that you do within your respective orgs.
I guess I'll go first. Hey, I'm Morgan. I actually started in harm reduction in New Orleans. I was living in a neighborhood where I had a whole lot of friends who were having a whole lot of overdoses and endocarditis and all kinds of stuff. So somebody tipped me off to a little organization called Tri-Stereo, and I got hooked up with some Narcan and started, and like kind of got hooked on saving people's lives. It was really neat. After I moved back to Alabama, I kind of just went really wild and was I started doing Narcan trainings and stuff, and somebody suggested to me that I maybe look into the legality of that, and so I was like, really? No way. Turns out that was maybe a good idea to do before I started. So I stopped, and that is how I got linked up with NASTAD, because I had to immediately figure out how to start getting legal access to people. And I had no idea what I was doing. I was a bartender in New Orleans 2 months prior to this, right? Mm-hmm. So yeah, that's 2 years later. It's been COVID and a whole lot of mayhem, and here we are.
Thalia.
Hi, everyone. Thalia Nakouzi. I use she, her pronouns, and I work for the Louisiana Department of Health, the Office of Public Health, stay with me, and I work in the STD, HIV, hepatitis program, and I am the health equity supervisor, so I oversee 3 different statewide programs. One of our programs is our statewide syringe service program, and I also oversee our teleprep program and our health models program. So 3 really incredible programs that we do statewide here in Louisiana. Obviously, our SSP program is very close to my heart. And I've had the honor and privilege of working with a lot of people, Allison Gay, prior to her transition here. So really excited to be here with you all. I came into this work originally, Laura had mentioned, New York and New York City. I'm originally a New Yorker. I grew up in New York City. So growing up in the Bronx, there were a lot of different factors that played into my long-term journey into public health. And then I think, working with a director who had worked in the Bronx during the crack epidemic, really kind of brought me into the harm reduction field and kind of pushed my trajectory into that work and working with individuals who use drugs and, making sure that they had access to comprehensive healthcare and comprehensive services and equitable care. And so down the rabbit hole we went, and I have moved to New Orleans probably about, 5 years now? And so excited to come back to this work and be working in this field again, so.
Thanks, Thalia. And really interested to hear how your sort of scope of work has shifted from living in New York to New Orleans as well. So thank you.
Absolutely, yeah.
Jessica?
Hey everybody, I'm Jessie B. She, her pronouns. I am in Southwest Georgia in Dougherty County. I am a registered nurse and educator and the founder of a little bootleg organization called 229 Safer Living Access, 229 SLA. Been a nurse 20 years, 17 in the ER, 3 in corrections. And I came into this because I found out my daughter started using IV opiates about 3 years ago. And we have nothing here. We have Athens, we have Access Point in Athens, and we have the Atlanta Harm Reduction Coalition, and then I'm way down here. And then there's Jacksonville. So people were dying, and my baby was close to being one of them. So about her third significant drug poisoning, I decided we had to do something. So I found the Georgia Overdose Prevention, and luckily we needed an Narcan trainer down here. And so I said, sign me up. So I thought middle-aged white lady with Narcan, I was doing some harm reduction. And then I really got out there in the streets and started meeting these absolutely amazing people here, and realized that, wow, there's a whole underserved community out there. Their arms are raggedy, they needed needles, they needed this, they needed that. And I started piecemealing that stuff together for my baby and her homies, and then her homies' homies, and then her homies. And so now I just have this little mobile thing that I do out of my Jeep. And I serve about 140 unique individuals every week by myself. And that's it.
Wow, that is significant. And thank you so much, Jessica, for talking about sort of your own lived experience and how you came into this work. I'm really excited to hear more about your mobile service delivery model. Thank you. And then lastly, Dr. Pollini.
Hi, I'm Robin Pollini. I'm on the faculty at West Virginia University, and I've been here for about 5 years. I'm not originally from West Virginia, but I'm from New Hampshire. So I'm a rural person by birth, and I really care about the health of rural people, and especially rural people who use drugs. My official job, my day job, is that I do research, harm reduction related research. So anything that relates to injection drug use, and a lot about how the environment influences both injection risk and also people's access and utilization to services like syringe access and naloxone and other services. I will also say that my route to this place and working in harm reduction is not all that interesting, but it's rooted in righteous indignation that as a scientist, we know that these programs work, and yet we seem to have a very difficult time getting them to the people who need them. I'm also a harm reduction volunteer. So I volunteered with groups all over the country, DC, New Hampshire, California, even Mexico. And it's really been my privilege to serve people who use drugs in all those different areas, most recently in West Virginia. And also just an honor to be on this panel with such amazing people doing really amazing work.
Yes, thank you, Robin. I also want to echo that as well. I'm really excited to be a part of this conversation today. I'm going to kick it over now to my colleague, Abiel. Thank you so much.
Yeah, thank you all so much for the introductions. I always love to hear how people get started in harm reduction. I just feel like there's no real traditional route to harm reduction. So it's interesting to see how people get started. But we can go ahead and dive right into the meat of the topic. And so the first question I want to ask, or hear you talk about a bit, is how is harm reduction in the South unique? So we can kind of just start. Anybody who wants to jump in.
I think that down here, you have to be willing to really buy in 100% on that whole meeting people where they're at thing. Because more often than not, that's going to be a place that makes you pretty uncomfortable. It's not tent city. It's not necessarily tent city. It's not necessarily an open air drug market. It's not necessarily going to be somewhere that anybody would be comfortable. It doesn't look like it does on TV. It looks like gummo, sometimes. And sometimes it looks like Mima's house. And sometimes it looks like the back of a school bus. Because you're giving stuff to the driver because the kids on the bus need to sneak stuff home, or they have stuff themselves, or whatever. I mean, it's a very different thing here. It might look like driving an hour and a half into the woods to pass off one bag of rigs. And it's worth it every time, even if you drive a big gas guzzling chunk of crap like mine. But that's what it looks like here. It doesn't look like 20 minutes on a train with a Metro card that it's funded by your organization, with a case of stuff that is also funded by your organization, that's funded by the federal government or whomever else is paying for the tab. Smaller groups like mine and Jess's and probably some other folks that are here, like that came out of my pocket until late last year. I know Jess is still paying out of her own pocket. I don't know. It's simple and quite complicated.
Yeah, I'll go next. Jessie B here. I don't know what harm reduction anywhere else looks like. I've never done it anywhere else. I know here it just looks like a whole lot of love. It looks like me begging and borrowing all week to scramble up, hygiene kits and little things to make people special, Ipsy bags and stuff for the guys, and just loading everything in the back of my Jeep and just going. I put my schedule out on Facebook and I tell, here, I would dare say most of the people who I come in contact with, they have a cellular device, and so they jump on Wi-Fi a lot. They always check my route, and I just go. I'm real consistent. I go to the same exact spots at the same exact times. I'm in the same exact vehicle. They know to look for me, and I work a full-time job because my lights have to be on, and I like to eat. And every time I go to outreach, I bring home a new cat. So there's that. We're up to 6 now, God. And then I work a part-time job teaching adjunct, and that actually pays my harm reduction bill. So just exactly like Leah Morgan said, it looks like meeting people where they are, hearing them tell you what they need, and making it happen somehow. It looks like not making promises that you can't keep. And that's kind of it.
Yeah, I mean, I think that, harm reduction in the South is so different, even in our southern states, right? Like each state is so different. In Louisiana, we have parishes, right? And also known as counties everywhere else, but like each parish, each municipality has their own law and their own ordinance and their own, and that's just one state. you know, and so Morgan's in Alabama, and Alabama has a completely different, you know, set of rules and culture, and Jesse's not far from me in Georgia, and it's completely different. So I think that's one of the big pieces that I have noticed in working in this field. And that's, you know, not to say that the Northeast or other parts of the country aren't like that, right? You know, but I do feel like being from the Northeast, you know, you can kind of say, okay, New York, Connecticut, New Jersey are, you know, have more progressive values or have more progressive laws. Whereas here, you know, we're in a very progressive bubble in New Orleans. And then you step right over into Jefferson Parish, which sits right, you know, hugs New Orleans. And the laws are completely different, and the policing is completely different. And the people are completely different in their values and their beliefs. So, you know, I think that is something I have seen very specific to the South. You know, yes, we are like this conglomerate of, you know, people, and people define the South as different areas too, right? Like there's the Gulf South, there's the Deep South, there's the, you know, East Coast South. I mean, it's so different. And I think that plays a really big piece, because we're all trying to, you know, do good work and put money into this and fund this work, you know, but it also is it just looks so different throughout our different communities. And that is challenging, and it can be really defeating, you know, because you get some certain things going on in one area, and that's only a small community compared to like a state at large or a community at large, you know.
So I always start in these meetings by saying that West Virginia's in the NASTAD South, but we don't really consider ourselves South. So I can only speak for West Virginia in general. I agree with what everyone has said so far. And I also think that in my mind, I sort of separate not regions, but more like urban, rural, both because of the type of harm reduction and outreach that you have to do, and because of the politics around harm reduction tend to be a little different in more rural areas where things are more conservative. To me, doing harm reduction in New Hampshire and West Virginia is sort of similar in that it involves going out in the woods. And so it doesn't really matter where you are, you still got to go out in the woods to get that Narcan around. The theme that you'll be hearing from me today is that we have new legislation in West Virginia that went into effect January 1st that severely restricts our ability to do harm reduction, syringe services work in particular. And so we really are starting to have this sort of dual system where we have legal programs, not as many as we had, but legal programs that are adhering to a really strict high barrier model of harm reduction. And then we have a growing underground force that, like Morgan said, is meeting people where we're at, because that's how harm reduction, you know, big H, big R is done. And that wasn't illegal 2 months ago, and now it is. So it's a really rapidly changing environment. And like everywhere, it really just depends on where you live and what the rules are and what the resources are. But I think everybody on this call has put a lot of miles on their car, ferrying supplies from one place to the other. I drive a Volkswagen Golf, and I really need a bigger vehicle to do this work in West Virginia.
I want to thank you all so much. I want to hone in a little bit more on some of the things that you all are fleshing out, right? So I'm thinking primarily about some of the barriers that you all talked about around like cultural sensibilities or regional differences, right? So the Deep South may not be the East Coast South, as Thalia and Dr. Pollini pointed out, or sort of some of the ways, the barriers around meeting certain people where they are, as Jessie B beautifully, both Jessie B and Morgan beautifully talked about. So I wanted to highlight and bring to light, what are some of the structural challenges you all have faced while providing harm reduction services, right? So I'm thinking, not only from the participant level, but what about organizationally, right? What are some of the challenges organizationally, but also community specific as well? or even legislative, as Dr. Pollini kind of pointed to.
I mean, I'll jump in right away and say that in Louisiana, we have 7 syringe service programs in the entire state, right? And so majority of them are based in New Orleans. And we do have programs in Central and North Louisiana. However, there is a huge pocket of our rural communities, right, that do not have access to syringe service programs that they can easily, you know, attend on a weekly basis, on a daily basis if needed, right? Like so I think that's, you know, a huge barrier that we face is a lot of our rural communities, if they're not close to like a big city hub, how are they getting supplies? And that sometimes even looks like people coming into Louisiana from Mississippi or Alabama, right? Like, I know we have a bunch of Crescent Care, NOSAP folks on here. And so, I mean, they could even speak more to it, but, you know, their program is seeing, I think I met with Chris, who's over that program yesterday or 2 days ago, and there's like almost 3,000 people that are coming to get, and correct me if I'm wrong, y'all, but, and so, I mean, people are coming from all over to make a trip, and then they're bringing supplies back, and they're, you know, so I think that for me is such a structural barrier, and a lot of it again is because of legislation and because of ordinances that are not being passed. You know, Louisiana had, I think it's 2017 that they changed from having, yes, Sonia, thank you. We have people coming from Baton Rouge, from everywhere. Yeah, so it's not just New Orleans. Thanks for that correction. But yeah, I think, you know, we have people, sorry, I just lost my train. But in 2017, there was an ordinance, you know, there was a law that changed it from being state-made mandates to municipalities that were able to pass ordinances. So that, you know, also changes it because we have so many little municipalities that are making these decisions and that enact and affect so many communities. And so I think, yeah, travel is a huge piece of that. Chris just said hundreds of miles. Yeah, people are really, I think that's one of the biggest barriers that we're seeing. You know, we just don't have enough SSPs that are able to operate at, you know, at large for our state.
And then those that are existing are already so scarce and so far.
Correct. And truly and honestly, every, you know, SSP in the state of Louisiana is working their effing butt off. Like, they are putting in the hours, figuring out nights and weekends and days. I mean, and it never seems like enough. Yeah, completely. Chris is right. And tapped out. Absolutely. Yes. You know, I mean, the overhead, you know, and I know at the Department of Health, we try, and Allison has been instrumental in this, but like trying to get more money to support these programs. And it just seems like, you know, it's never enough because there's always, always, always more that needs to be done.
Mm-hmm. Mm-hmm.
I'd like to jump in on that if I may. I serve 7 counties in 4 states alone. So like, I fucking feel that, yo. But also, that's a lot of charges to look at. So I didn't just say that, right? I mean, that's the thing. Huntsville, if you drive an hour in any direction, you don't get anywhere. You're still in the woods, you know, like get on an interstate, get on a highway, pick a direction and go. It's 100 miles before you get anywhere. So you've got Tennessee, Mississippi, Georgia, and a whole lot more of Alabama before you get to any place. The next biggest place is Birmingham. North is Nashville. To the west, there's nothing until like Texas, maybe. East of us, you eventually get to Atlanta. It's about 3 hours. Memphis is kind of sort of close. It's also about 3 hours. So anybody that's in, that little circle got a ways to go. I drive that a lot. I go to Mississippi. I go to Tupelo, Mississippi. It's uncanny to think about somebody coming to a window at a building that I don't live in, where I get to leave at the end of the day and leave work at work and be at my home. That would be a freaking dream. I would love to be tapped out in that capacity. That would be so nice. But like the way that it is right now is where I either sit at this desk where you see me right now, or I'm in my car boogieing around the Central South. Like it's a lot. Also, yeah, I said none of that.
Safe space. Safe space.
Yeah, no, absolutely. I want to definitely a safe space, Morgan. Jessica, or Dr. Pollini, could you talk a little bit more about some of the other barriers that you all are facing?
Can I jump in just a little?
Go ahead.
Sorry, no, I'm just curious. I want to just directed at Robin too. I just a couple of threads that people are picking up have been, talking about here. Thinking about policy and how it interacts with rural spaces and the ability to say have secondary exchangers or mail-based naloxone and mail-based supplies and services. And Robin, I know that so much of the really awful legislation that was passed in West Virginia, outright negates those things. I guess I'm curious if you can also speak a little bit to some of the ways that you as an academic try to capture some of the data that evidence need. Mark Burrows in the chat put in a great little comment there about how much you all save in your communities, not just how many lives, but like how much in terms of services and catching people before they get endocarditis and all of those things. Are there ways that you all think through capturing the need, the spread of your geographic catchment, things like that, to help build support for local electeds, for other community members, for towns, counties, states next door? Did that make sense? I feel like it's a similar question.
Yeah, so yeah, I was kind of going in that direction. So I wanted to piggyback off something Morgan said, which is that it should not be a crime to provide evidence-based harm reduction services. That just needs to stop. Like, people are out there saving lives. The science shows that it works, and it should not be a crime. So full stop. The second thing I want to say, like from an academic perspective, is that we know that these programs work. And so what we're seeing in West Virginia is people saying, okay, like I'm going to concede that works, but it needs to be highly regulated because people need to be accountable who are using drugs. And so what that means is that in West Virginia, they're creating a system that doesn't work for the people it's supposed to be working for. It's highly restrictive. Everything in West Virginia requires a name. You have to have ID to get syringes. You have to give your name to get naloxone at the pharmacy, if they even sell it. Until I started a project a couple of weeks ago, there was no anonymous HIV testing in West Virginia, even though we have 2 outbreaks. So there's sort of like over-regulating what people don't want, and also building the system that just doesn't work for the people that we're trying to serve. And so the research, and I saw a couple of comments in here, the research can help to kind of reveal what's working and what's not working. But it's, the impact I'm having in West Virginia is not largely due to my science. It's due to the stuff that I do in my spare time that's actually reaching people where they're at. And sometimes that means like buying naloxone for an entire town out of my pocket, just like everybody else is doing on here. And it's not even the town that I live in, right? So I think it's a really frustrating time to be a researcher and a scientist in this field, because it doesn't, at least in West Virginia, doesn't feel all that helpful. But then there's an opportunity to do the research on the programs that were just implemented to show how they're not working, and then see if we can do something about that. So yeah, that I think that's what I'd say about that. Like, we are building systems here that do not work, but people feel comfortable with those. And it's up to the people doing the illegal work to pick up the slack. I have a colleague / friend who reversed an overdose the other day with naloxone that came from California. That was donated from California, because we literally have not been able to get our hands on Narcan that's purchased by the state of West Virginia. So the system is broken. It's just broken.
It's really difficult to gather quantitative data when it's illegal to do the work that you have to do in order to get the data. I can't prove the need if I can't do the work. I can't show you a success if it is illegal for me to do the thing. I would love to show people that it's a perfectly valid and evidence-based practice, but I'm not going to prison for producing the evidence.
And for me as a researcher, I can actually sort of do that legally, but as you more highly stigmatize things, it gets harder and harder to get people in the door, particularly in communities where I'm not well known. We now have a fentanyl passive exposure bill pending in our legislature, which is going to further marginalize folks. So even getting people in to do like NIH funded research is really difficult in these kinds of environments. Yeah. And also just looking at the comments, like, everyone should get paid for doing this work, because it saves lives and it saves money, right? But I think most of us would say that it's costing us money, and that's fine.
And to go even further, like, paid equitably. We obviously the Department of Health, we have a lot of contracts with our SSPs, and like sometimes I sit over here and like I'm furious writing these contracts, looking at salaries for our SSP staff contract. It's not equitable pay. And I know that people are doing, I think a lot of the times people come to this work because they're driven to this work and they're passionate about this work and they believe in this work. But that shouldn't mean that they are not paid equitably for this work and they are not compensated for the extra gas and mileage and late nights, and so that's a hard piece as someone who's not sitting in an ivory tower, but like, as being a state employee kind of piece is like, I'm not necessarily in the field and I'm looking at these contracts and this money that's dispensed, and that's frustrating too, right? Is to say this money that we're paying should be enough and it's not. And so that's that other piece.
I guess I can jump in here, Jessie B again. As far as, the participant level challenges, I just started going out there. And then once I got out there, I realized that I knew a lot of the people that needed the services, either from the ER or when I had worked inside of our county jail, which is actually a 1,200 bed maximum security facility. Our hospital contracts with them to provide nursing services. So I was one of the 2 registered nurses that worked there. So I'd already formed a relationship with a good number of people and already had a good name. So that was, so I set myself up for success by just being a decent human being. So that was not that difficult. That and the fact that I was real dumb, that I just did a lot of really reckless things, not knowing any better. So it's amazing that any of y'all ever got to meet me at all, truthfully. Last year, well, I'll tell you, I spoke with our EMS director. He and I are pretty all right. And he told me, he said, Jesse, he said, he said, now that we've got a full year of data that you've been in the street, he said, last year we ran 100 less drug-related calls than we did the year before. And we had 10 less drug-related deaths than we had the year before. And he told me, he said, and that's directly related to you getting naloxone into the hands of the people who use drugs. So, you know, that's just me, you know, that's just one person doing the best that I can with what I've got. My mind actually just, you know, races. My heart just sped up like 30 beats a minute, thinking how much impact could be made, hell, with just another person, 2 people. If instead of going out, I go out one whole day a week, and then I piecemeal smatter it in here and there, kind of trying to hit people that are maybe new to the program, just got referred. You know, my baby's out there and she's constantly, hey, mom, I just met this new girl, I just met this new guy. Can we help him out? Can we do this? We do that. So I'm not going to make them wait till the next run. No. And then find out something happened to them in between here and there. So that, you know, that's the thing here. When I started doing this, I didn't know anything about it. Like I said, I was real dumb. I didn't even know harm reduction was a thing. I just knew that my kid kept going into respiratory arrest because she kept getting dope. She didn't know what it was and was trying to kill her. And so I didn't know. So I had been doing this almost 1.5 years before it ever occurred to me that you ain't talked to the police, you ain't talked to the DA, you ain't talked to no damn body. You just out here wilding. And I said, well, at that point, I mean, it was done's done now. So I retrospectively made contact with people, kind of happenstance, and they're all right with it. I mean, it's kind of, I don't know. I mean, I kind of feel like a dirty little secret sometimes, but like they know what I'm doing, and it's like, as long as I just stay over here and shut up and be quiet and do what I do, then they don't bother me too much. I know somebody had asked about police contact. Now, the police officers here in town actually really, they really support me, believe it or not. I don't work with them. I'll work beside them, kind of, if I have to, a little bit, maybe just like over here, but not, but they say if I'm in an area doing stuff, if they know that I get to go into an area and work with a group of people, that they generally have less calls in that area. You know, I wish I could get some data on that, but it's just me, so I can't.
I think I have a pretty similar situation with the police here. I asked one officer because he was going to be the guy that I'd run into the most often at the tent cities, and you know, I gotta ask his permission, kind of, sort of, a little bit. So we have a don't ask, don't tell policy there. Otherwise, we have a real don't ask, don't tell policy with the police. My number one priority is my participants. The police don't have their best interest at heart, especially not if they're Black folks. So we just don't talk to those guys at all.
I actually want to dive in deep into this idea of racism and policing and hypersurveillance. In fact, a person, Tamika Jackson, honed in on this in the chat around sort of racism being really one of the strong barriers within harm reduction, providing harm reduction services in the South. Could you all talk about that? But also I want to think about this in relation to, and both Jesse B and Morgan have already kind of given light to this around sort of the hyper criminalization of people who use drugs, right? So I want to ask a question, right? Given the realities of police violence, right, and the hyper-criminalization of people who use drugs, what role does law enforcement or even other punitive systems have? What roles does law enforcement or other punitive systems play in harm reduction services in the South? And also to that, from a racial equity standpoint, how do we see the ways in which race and racism function within this context?
The number one killer of people who use drugs is stigma, period. Period, end of sentence. And next, probably cops. Like, or the fear of them. I'm not gonna monopolize the rest of our day talking about racism in the South, though. But it's bad, and it absolutely has contributed to the discomfort up to death of at least 5 people I know in the last year, 365 days. I mean, personally, no, they're mamas. You know, in the last 365 days, I've lost 5 to racist cops and their bullshit in the South. So call it what you want to, but it's here. It's not going anywhere anytime soon. We got to do something.
Yeah, I would agree with Morgan. I think the role for law enforcement and harm reduction is none. It's a public health intervention. It is not a law enforcement intervention. It is not a legal intervention. It's a public health issue. And I do not think that police have a role in that. There's piles of research, including research that I've done that shows that interacting with police increases risky injection behaviors. We know that incarceration increases risk of fatal overdose on release. And so I just think the easy answer is none. There is no role, period.
I'll go next. Jessie B here. Now my situation's a little unique. The county that I live in, the town that I'm blessed to be able to work in and serve in, is 77% Black, not BIPOC, Black. And most of our police officers, our deputies, are Black. So what I get to see is different. The police brutality, the harassment of Black officers on Black drug users is unconscionable here. And I don't understand it. I can't, obviously. I see it though. I've lost several participants the same way Morgan has. You know, the stigma kills, the shame kills. And then I've got Black people who are looking for help, but they got Black people that they're in their mind they should be able to call, but they can't call. So, you know, many of the EMS here, I mean, we're at 77% Black. Most of the EMS are Black. So I don't know, you know, it's hard being a white person looking and seeing, and there's nothing I can do about that. I just try to be a safe space for people. I just try to make sure everybody knows that they truly can come to me. And it's hard.
Yeah, thank you guys all for addressing just exactly how hypercriminalization of people who use drugs or police violence, law enforcement, racism, how those all play major or have major impacts in the way that we provide services and the way that our participants accept services. Much along those same lines, COVID-19 has affected the way that we provide services and the way that people accept services as well. And so over the last year, we've seen higher rates of overdose in the South amongst people who use drugs, namely due to the ongoing devastation caused by COVID-19. How are health departments across the South plugging in to address these trends? In your research and experience, what do you think are some of the best practices, and what are some challenges that you see and face in the intersection of COVID and harm reduction work?
I mean, I think, obviously COVID has impacted work, in so many different capacities. Here, like even at the Louisiana Department of Health, we've had so much restriction in our community health workers and our, DIS staff that are able to go out into the community and do in-person work. There has been so many restrictions and so many barriers and so many different layers of what needs to be approved, and then travel isn't approved if you're doing it anyway. So like that's just like structural stuff. But even people, ride sharing to their local SSPs, I think that's, with COVID, there's been that layer of fear and safety. And staff that are working, COVID has had such an impact everywhere. And I think for us too, it's been a lot of our SSPs have stayed open during COVID. And so, there is staff that are exposed or, clients that are, it's scary. And there's so many different layers to this, COVID has just added on an already stigmatized area of work, scope of work, it's added like another layer of, it's another barrier. It's another restriction. Even in cases where, restrictions are put in place for the safety of others, right? Like it's still a restriction, it's still a barrier.
We have, this may be more of a rural issue than a urban issue, I'm not sure, but many of our health departments just have 2 or 3 full-time staff. And so for example, down south in Wyoming County, we set up a lovely little mobile harm reduction program. But when COVID came, they have 3 full-time people in that health department and they couldn't do both. And so that program had to shut down. We've also had issues with response to our HIV outbreaks, with HIV testing just completely shutting down because all of the health departments were focusing on COVID. And so there just isn't enough bandwidth. I think it unveils a real weakness in our public health system that we cannot respond to 2 emergencies at once.
I got trained and like CLIA waiver certified, blah, 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 to do HIV testing because of that very specific issue here. Alabama is a phase 1 state for the EHE initiatives. The only reason we don't have a similar story to Huntington or Scott County is because there's not enough testing. If you don't test for it, then you don't have a problem, right? We did that with COVID too. So yeah, I mean, I'm out there doing swabs on people and letting them smoke cigarettes or whatever they need to smoke while they wait their 20 minutes. It's a tough gig.
Yeah, I think
it's a really hard gig.
I think we are vastly underutilizing HIV oral swab rapid testing. I mean, anybody can do that
Yeah, I mean, it's cheap and you can get trained to do it in about 20 minutes. I mean, it literally takes no time at all to figure out how to do. they should be out there. I mean, we can't mail 4 of them to everybody like we just did with the COVID thing. Why not?
Jessie B again. You know, down here we've got an amazing health department. Doherty County Health Department is it is amazing, all the way at the end of the damn county though. It's so far out of the way. I don't want to go there, and I've got a vehicle. We've got a bus system here, but it only runs. It runs. It almost runs the hours that people don't need it, so that they don't have to run much at all. I mean, it's so ineffective. There's no restaurants down by the health department. There's no hotels. There's no nothing. Nobody's going to do that. So I partnered up with them to get their safe sex supplies. Their condoms or lubes or dental dams. So excited. Hey, it's something I don't have to pay for. I walked in one day to get my things, and I saw these boxes, stacks and stacks and stacks and stacks and stacks and stacks of bags. They had dust on them. You could plant taters on them. I said, what? I said, Lamaya, what is this stuff here? She said, oh, Jessie, those are OraQuick HIV tests. I said, what we doing with them? She said, nothing. I said, nothing. She said, no. She said, nobody asked for them. She said, no, nobody. I said, well, hell, I didn't know you had them. So that's something I do now. The health department, I'm doing all their safe sex stuff, and I'm doing all their rapid HIV tests. But yeah, I take my tests out every week. Every Monday, I take the health department's HIV tests out, and I've started testing people, and it's really that's such low-hanging fruit. COVID didn't really hit us hard. No, that's not true. We're the town that kicked COVID off in March of 2 years ago. We're the town that had the funeral where all the people died. Albany, Georgia. We had mobile morgues in our town for months. But COVID did not impact my participants because they stay so isolated. They stay in their communities with their people. They don't travel about much. They don't go around much. If they got sick, it would be me. It would be me bringing it to them. I would be the vector. So we just kept doing, we just kept it going like we were going here, thankfully. But I was able to discover that little hidden gem of HIV, oral HIV kits, and start testing people, and then, doing linkage to care. So it is a hard gig, Leah Morgan. It is hard, ain't it?
Very first swab I delivered came back positive. That was a bitch. That I cried. I went home and I cried.
I tested all. We have a community. There's a hotel, and it's well known that a lot of the sex workers they live in this one hotel. Somehow I hadn't had a positive one yet. I've gone back and tested them a couple times thinking I had bad batch tests. I hadn't had a positive one yet. So we're hooking them up with PrEP.
PrEP is super underutilized in the South, by the by. It's people don't even know about it.
They don't even know about PrEP Pred, but we're getting them all hooked up with that stuff. With that too, that's so easy, so simple.
I want to kind of tie this all together in terms of sort of the creative strategies you all are doing, the innovative research, as well as highlighting some of the gaps within this work, primarily in Southern harm reduction. Could you all talk a little bit about what particular areas of Southern harm reduction in specific would you all like to see bolstered or emphasized more? I feel like you kind of was going somewhere and you talked about PrEP services or PrEP navigation, but what services would you like to see bolstered in Southern harm reduction?
Southern harm reduction at all would be cool, maybe.
I mean, I will say till the end of time, like Morgan, I completely agree. money. I mean, I know that's not a service, but like, I just want to see as much money as possible coming in to the South around harm reduction for our SSPs, you know, and I mean, I think that capacity wise is just like, that would change so much. Like the more money we can see coming in, the more maybe even sustainable some of this work is, because that's the other piece of this. So, but I mean, I could talk forever about all the things I want to do.
I see someone in the chat. Tim said less funding for abstinence-based services. Yes.
Absolutely, Tim.
Less funding for religious-based programs.
Yeah.
Less of that. There's a lot of religious trauma in the South. If anybody's ever read Salvation on Sand Mountain, that's 30-45 minutes east of here where I live. Sand Mountain is snake handling territory. It's also Meth Mountain. That you can't really go function there the way that you do other places in the South even. That is a really insular community. And if you're asking somebody to leave all of that and beating them over the head with a completely foreign concept of life, then also bashing them about the face with religion, you're just welcoming failure. You're welcoming abysmal rates of success, if you want to put it in I guess a positive way. But it's you've got to undo many generations of trauma. Really, it's just all trauma, and hard living, and a culture of people who have felt completely abandoned by the rest of the country. We get ignored down here a lot. We get underestimated a lot. People think we're stupid. People think that we're a whole lot of things, and we're painfully aware of it in every aspect of being a Southern person, I think. And undoing that takes a lot. I'm sorry about my dog. But yeah, no, we've got a lot of work to do in the way that we approach the South and Southern people too. There's a lot of condescension from a lot of corners of the country when it comes to that, as if there's not ignorance and hatred everywhere, and as if the very same attitudes aren't being expressed when we speak about the South and Southerners. That hypocrisy is something that we've lived with for a long, long time, and it's not helping anybody.
I think that, this is harm reduction 101, and like, I can't believe I have to say this, and it's public health 101, but we have to build systems that are designed for the people that we're trying to serve. We have to stop building programs that have no input from people who use drugs and just expecting that they're going to work, and then blaming people because they don't use them. The other thing that I'll say about funding is, it's not just how much funding, it's where is that money going? So we've had a lot of money coming into West Virginia. Nobody that I know who does work on the ground has seen that money. Nobody, right? We're paying out of pocket. West Virginia is really everyone thinks it's the epicenter of the opioid crisis or the drug crisis. We are getting naloxone donated from California. So where is that money going? And is it going to places that are really saving lives? And if not, how do we make that happen? So I think not just how much money is it, but where is it going, and is it really doing what it's designed to do?
Yeah, no, that's a really good point. And I think serves as a good kind of segue into my next question here. I've heard points of building systems that are made to work for people, funding, where is the funding exactly going? Is it being seen on the ground? And that brings me to a point of meaningful involvement of people who use drugs. And so I just kind of my last question before we, and for the sake of time, want to allow some Q&A from the audience as well. But how does or has meaningful involvement of people who use drugs inform your service delivery model? How can you envision it informing legislation and harm reduction in the South in general?
We would like less legislation, not more of it.
Yeah, that you can't legislate away bad legislation, right? Like that doesn't, it's like burning the house because you can't keep it warm. That doesn't make any sense, right? Like it's not going to get better with more of the same stuff. So I don't know, maybe we do burn it down and start over.
I don't know. Jesse be here again. Yeah, Mark, that's fine. I don't really know the answers to some of these questions because, you know, I'm gonna kind of go back to what we were talking about before this question. Leah Morgan was talking about how people think we're dumb down here, and they do. I find myself saying a whole lot of times to people, I'm a lot smarter than I sound. Even my accent is a barrier when I'm trying to engage with people outside of here. I was born in Kentucky and I grew up going between Western Tennessee and down here in Southwest Georgia. That's how I've got this, I think, a beautiful kaleidoscope of an accent. But even that alone, people think, oh, she's real dumb, isn't she? No, she's not. You know, syringe access is legal here in Georgia. It has been for a while. It's just nobody's doing it. And because everybody's scared, the good old boy system, it might be legal, but we don't want you doing it. We're going to push you out. And, you know, we've got this real nasty little Facebook page that's down here in this area. I don't even know what they call it now. It's so nasty. And they talk about people overdosing and they talk about people getting arrested and talk about this, talk about that. And every now and then they'll make slick little comments about, well, call Jessica. She'll do this. She'll do that. Well, first off, if you're calling me Jessica, you don't know me. So I just had to kind of block that out. It's just it's legal here, but all that does is keep me from going to jail. It doesn't help me get the services to the people, even though the director of EMS said 100 less calls, 10 less deaths, but what we do still vilified.
Yeah, I mean, I want to like really echo that. I think a lot of people don't know, especially from outside of the South, that a lot of majority of movements and change and has been born out of Southern movements and have started here and have spread, you know, countrywide, but people forget where a lot of that hard work and a lot of that on the ground grassroots organizations. I mean, you want to talk about some of the smartest people I've ever met are living in the South, hands down, the most creative, the smartest. I struggle with the word resilience because I think, you know, it's a hard to be resilient it's great to be resilient, but it sucks when there are things that are out of your control that make you resilient, right? We hear that a lot here in Louisiana. Oh, Louisianans are resilient. Yeah, well, natural disasters are out of our control. We don't have a choice, right? So, but I think, so that is frustrating. Even when I talk to colleagues that I worked with in New York, they'll always be like, oh, but it's the South, it's different, it's behind. And I'm like, you have no idea the creativity and the brain power that is coming out of the South and the change that is being enacted, and the power that comes from the South. So I very much agree with that. I also think, I would love to see more respect, more value placed on people's experiences, people's lived experiences, individuals who are working with those who have, with individuals that do use drugs, their knowledge, their experiences being valued appropriately and with respect when they are asked about, what laws or what legislation or what, we're working here in Louisiana right now for this upcoming legislation to decriminalize fentanyl strips, or to remove it from paraphernalia, right? So that people are able to carry them. And I would love to see more real life people having that conversation. And when they do share experiences and when they do share knowledge and what they're seeing in their communities and the importance of removing certain things from paraphernalia coding, like I want them treated with respect and I want their voices to be valued and not tokenized, because we do that all the time. Like, oh, we're going to have an advisory board. Yeah, I think advisory boards are great, but like, are we really listening to our advisory boards? Or are we doing it to fulfill a grant that is then going to give you the money? I mean, so that for me is something that I'm one person, but I mean, I think that that's something that I try and think about when I'm in these spaces and I want to lift up more. Yeah. Community advisory boards, cabs. So yeah, I mean, one of the grants that we have is paying for cabs, but that's also putting work on our SSPs to get a cab together and pick people to come. And it's just like, that's a lot too, I mean, that's a whole nother piece of work. So yeah.
I think it's really important to just really drive home how much harder it is to get ahead or to appear progressive or to seem like you're doing the work when you're coming from so far behind, not only in people's perception of you and what you're doing, but what you have to work with. When you start out having to prove that you're even worth somebody's time in the rooms that you're in before you can begin to work, of course your shit's not going to look that great. How far did you have to drive to get to that meeting? Does your internet work? Because I'm telling you, it doesn't most of the places I know down here. There's a hill in the way or something. They put a lake in there a couple of years back and now we don't have a road. So we got to drive all the way around East Jesus Nowhere to get somewhere that used to be 10 minutes from here or whatever the barrier is. Look, like, you think I'm stupid because I talk funny. Like I can turn off the I don't have an accent thing real quick and get just as trailer trash as we want to be. But I'm not gonna today, even though like we're picking on some of my spots right now. But look, like if you weren't gonna take me seriously when I walked in the room, then you weren't. And I gotta fight that in every one of these rooms I walk into before I ever even start doing the work. Now look at me and tell me that what I'm doing isn't as good as somebody that's got a funded program in a state where it's legal or whatever. And that's fine by me. You just go ahead and keep on underestimating me and I'll fuck you right up.
Yes, thank you for really good input into how people who use drugs, how their experience needs to be considered in a lot of our service delivery and just the entire harm reduction landscape in the South. I did want to open up the floor for the audience. Do want to have a few minutes for some Q&A. I see that there's some really good questions and comments that are being put into the chat directly. And so I want to welcome anybody who has any burning questions that they want to get answered by our wonderful panel here, or if you'd like, you can unmute and ask the question directly. So just want to give a few minutes for that before we close out the session.
Or if not, I can go into the chat and read some of the questions that were asked.
There was one about like science and like being a researcher and how that impacts things. I've been struggling with you calling me doctor during this panel. Like that's a privilege that I have, but also I think it's pretty clear like everybody on this panel is a doctor of harm reduction. Like that's been earned. And just because I have that certain title, like doesn't mean we all don't deserve it. There's probably many people on this call who are much more qualified than I am to be talking about this. Science like is really tricky. Like I came to West Virginia thinking, oh, I'm a scientist and I've been studying this stuff for a long time. And obviously I can do great things. And honestly, that hasn't mattered as much as sort of trying to hold people accountable to the science. My phone doesn't ring with people who want to know how to make the best science-based policy around drugs. Like no legislators ever asked me that. And when I did some work in New Hampshire, which is my home state, it mattered a lot more that the chair of the committee that was in charge of passing that legislation lived down the street from my uncle, than the fact that I was a doctor person. And so I think, I don't know if this is true in the South, but it's certainly true in rural areas that a lot revolves around relationships and person-to-person interaction, as opposed to somebody being like a doctor or a scientist. But I am able to wield that in some situations that might be useful. But to be honest, I haven't found it as useful here as I would like. It's a really interesting time. Like science and public health are under attack in a variety of different ways, and I feel that pretty much every day.
I have a funny question. I don't know if it's a good question to end on though, but something that I've been listening to through this, and something I've experienced, it's come up a couple of times, this idea about being judged because we're from the South. I actually find, I grew up in Southwest Missouri. I've lived in really rural little place, and I've lived all over the country. Do any of you have thoughts about how being from the South or being from a small place makes you more relatable in this space to communities that you work with or health departments that you work with? To me, there's something very unique, or Thalia, I guess you could say the opposite, right? That being from New York kind of makes you distinctly unrelatable in some ways in the South, and that's something you got to fight down, right? I guess I'm wondering if any of you can speak to how this being from the South, being from a small place, is a straight up strength in engaging with some of these conversations.
Well, I'm used to it, you know. Like the struggle has been real for a long time, so it's not anything new. It's not a surprise. And I mean, yeah, something Thalia said earlier was that you know, we're creative, we're problem solvers. When you've got nothing, you figure out how to make it something really quick. You know, that's a talent. I can make groceries out of nothing. And I can do the same thing. I mean, you know, we work miracles every day, some of us. But I think also like the way that we interact is different. There's a lot more to that whole Southern hospitality thing than just a casserole. You know, I mean, look, when time gets hard, I cook. Like that's a stress relief, for better or worse. But you know, it's that whole like one loaf of bread, one little tiny fish fillet situation. I can feed a whole camp on one piece of trapezoid fish like nobody's business. It's pretty great, really. But I'm tired of it. I'm tired.
I will say, I mean, I'm not from the South, but I do think that there is like the importance of relationships that I have seen is so different. You know, I mean, being a New Yorker, not that relationships aren't important, but it's just a different culture, right? Like here, if you build a relationship and a foundation with partners, with, you know, with your colleague, like there is so much more trust there. And then to have conversations and then to, you know, strategize together and then to build together, I think is more important to me than anything else. Because that relationship, you know, once you build that relationship, that kind of sets the precedent for how you're going to move through whatever comes next, right? And so that's something that I think is so beautiful about my experience in the South, is like building those meaningful relationships and you know, obviously there's transactional too, but like not making it so transactional. And I think that that's something that's different than other parts of the country and other relationships.
Yeah, I can't speak for the South, but definitely being a rural person matters. The fact that I'm a rural person from a town of 3,000 people really matters when I go into towns of 1,000 people or 3,000 people. And then I get to know their families and their what, like it's a relationship. I also think that part of that comes from West Virginia, where I'm from in New Hampshire too, is being communities that have been exploited by outsiders. And so outsiders are not particularly welcome here. And so you have to situate yourself within a frame that makes you not an outsider. And honestly, we've even felt this from research. Like early on, we had a lot of researchers trying to come in here and get money to do research in West Virginia, but like literally didn't want to come here to have a meeting, right? Like, oh, you can come to New York and meet with us about the project we're going to do in West Virginia. There's a very high level of sensitivity to exploitation and outsiders that if you can work within that, I think it's helpful.
I know that we only have a minute left. Are there any more questions that folks want to ask before we go into a final closeout? I just see folks, I'm reading the chat, I see folks chiming in and co-signing alongside all of you all. I want to lift that up. Are there any other questions folks may have?
I'll just say I really appreciate you all coming to this conversation and everyone in the chat. Yeah, I'm proud to live in the South, so.
And on that note, that concludes this panel. This opening plenary has been amazing. It has been a wonderful discussion. I want to thank each of you for just your love, your labor, and for doing this work and just showing us the amazing creative and innovative strategies you all are doing in your respective jurisdictions. So this concludes today's opening plenary. And now the time is now 1:30. So we are currently going into the break session for 15 minutes. And after the break, you can attend one one of the following breakout sessions. There are 2 concurrent. So the first one being equity and treatment access, ensuring people who use drugs receive the care that they deserve. Or you could attend sex, drugs, and autonomy, approaches to sexual and reproductive health and harm reduction. I look forward to seeing you at either session, and you all have a lovely, lovely day. Take care. Thank you.